if you want to introduce yourself,
Okay.
I think that's a good thing for everyone to know.
Okay. So I know it probably sounds weird. I'm actually, I like to tell people that I'm the daughter of a political refugee, because a big part of my work ethic was born from being the daughter of somebody who came to this country at 17, who had nothing and didn't even know how to speak English. And through the years of me growing up with him, watching him, how he was able to hustle and persevere through some pretty big challenges, which really sort of taught me that in order to work in this world, you really had to grow duck feathers and let it roll when things didn't always go your way. And so knowing that I went into the field of behavioral health, and that was really an accident, not one that I actually planned, but one that I always tell people was a calling that picked me, and so grateful that it did. But it was also, you know, again, I tell people I didn't wake up one day and say, I really want to work in behavioral health and specifically work with people who are struggling with addiction. So for me, you know, I'm a daughter. I'm a mother. I have a 22-year-old son, Ethan. I have a husband I'm married to for now 32 years. Um, I'm a little bit of a gypsy. My husband and I have moved around a lot in the time that we've been together, always looking for new adventures. And in that time, I've been able to foster a career that has afforded me the opportunity to feel like I could give back in a meaningful way, most specifically in the behavioral health space, which has been really a reward for me. Um, I have, um, you know, a desire to help other people look at ways to better themselves. And I try to look at the assets of what people have and help them, be the best version of themselves. And I've been very fortunate as I've evolved in my career to move into leadership positions where I have a chance to help mentor and coach the folks that I work with. And some of it has been through trial and error. Some of it's been through, being led by other people and learning about their leadership styles and deciding on what works for me and what doesn't. And then really sort of evaluating each person that I work with and really getting to know them authentically to figure out how I can best support them in being the best version of themselves. So in addition to working to try to help people find access to services and treatment for mental health issues and addiction issues, I've also had the ability to help support people in leadership through, helping them level up in where they can be in their life. Whether that's the best social media manager, or the best BHT behavioral health tech, or somebody who works in technology who might be a CTO but has a really lousy, you know ability to communicate, to help them learn how to communicate better with other people on the team, to working side by side with other leaders and, you know, really kind of helping foster their best version of themselves from a leadership standpoint. So I feel like I've had sort of an eclectic growth period in my career where I've, been able to work in behavioral health, but I've also been able to work specifically in areas of marketing and, you know, organizational development, leadership development, helping out with alumni engagement, helping out with outreach and business development and sales. So, if somebody were to ask me, did you go to school to learn all this stuff? I would say no, life was my school. A lot of it was just being surrounded by really brilliant people that I was willing to listen and take advice from and learn from, and then apply that into the work that I do every day that, sort of feeds my soul.
So I was thinking about, when you were introducing yourself, something that I sort of did when I spoke to Carver Brown, and that one's going to get released shortly.
Mhm.
Um, because it's and really with Jim as well. But for you, I wanted to share not only what you sort of see as yourself and things you've accomplished and things like that, but sort of share what I see in you. And one of the things that's making me like really glow inside is one of the things that I wanted to um, say that I thought about you observe in yourself. So that makes me really happy that you're not walking around not knowing this about yourself. But I do think, having spent the better part of 20 years, working in different client situations with you, really seeing and appreciating how much you bring out the best in everyone around you.
Mhm.
I think that's a quality that I think is undervalued. I think in business, and probably just in social, you know, aspects as well. The people that you bring together is more than just a specific set of skills and levers that they can pull really well. And if everyone can learn to trust each other and support each other, then, sort of, to use another sort of thing that you've done before, which is sort of, 10x it.
Mhm.
And I think that really sort of an amplifier that truly is important. Another thing that I've sort of witnessed is sort of how honest and fearless you are about that. Um, and it's rare that you make a mistake, but I've seen you own it, openly every single time. I
Mhm.
think that's really, important. People can really trust that, okay, you will own up to that. So, and you recognize your faults, and you'll fix them.
Mhm.
And that's not something that they have to worry about with you.
Well, these are very nice things to say. My goodness. I didn't realize we were going to be having a conversation like this. You're just making me feel all good inside. But I appreciate you recognizing those things. It really means a lot. And as we say in TPAS, thank you. I like hearing that. So it really is nice to be acknowledged for those types of traits. So that means a lot. Thank you.
Um, I think I did mention that we've worked a long time in many different kind of situations. I think every organization is a little different, has different challenges, and one of the things that I think you and I have worked well with is recognizing what those are, and then figuring out, okay, what is the solution specific to them. Um, and That's always, uh, I think, something critical, and some that I really enjoy about working with you. So when you think of introducing change to an organization, and Lakeview is one that immediately comes to mind, but I know that there's others. I think there's things that people can benefit from looking at that as a bit of a case study.
Mm,
It was a very, very different place before you walked into it, and when you left it.
mhm.
So, I mean, if you were going to tell that story and what your learnings were along the way, and when you reflect on it, what are those areas that you can bring to table to the next situation that says, okay, we can do this. This is something I've seen before. This is what we need to do.
Mhm. Yeah, that's a great case study actually. It's probably one of my, top 5 sort of uh, watershed moments in my career where I was able to be a part of something that was incredibly transformational. And let me say from the outset, it wasn't a single person. It was definitely a collective of people that were on the same page, which I would say from the get-go needs to be the number one thing that happens from a leadership perspective is that there's a very clear path and understanding of what the objectives are so that everybody is on board. But then culturally that everybody understands that it's going to be a ride. It's not going to be something that's going to happen overnight, but that there is going to need to be some patience and time dedicated to making that shift happen. When I started at Lakeview, first, I was recruited to Lakeview after working for 6 years in the field, back to Florida. And for a lot of folks who might listen to this, they know that at that time, back in the it was like 2011, 2010 time period, there were a lot of things happening in Florida that were really questionable around ethics. And Lakeview was a part of that. It was owned by previous owners that were not doing things ethically and morally correct. I was aware of it all the way up from Virginia, where I was living, and when I got called by the recruiter to take the position, I was like, no way. I'm not relocating my family to a program that has such a bad reputation. So there was a lot of trust and a lot of leap of faith mentality for me that went into making that decision because it wasn't just, hey, I'm going to take this job and work remotely. It was, I'm going to uproot my family and my young child and we're going to relocate to Florida and give this thing a shot. So it was definitely a leap of faith for me in my career. At the time, there was somebody that they had brought in, and, somebody I hope you get a chance to interview, Roy Serpa, who, did not come from the behavioral health field. He had home health care background, which made me go, what is this guy going to do? How is he going to be beneficial to us in helping us grow? And what he brought to the table is, yes, he had lacked the intellectual knowledge around behavioral health, but he had extensive experience around culture change. And he knew how to bring the right people together so that we could actually turn the ship. And so I met with him, and honestly, he had me at hello. He adopted a servant leadership model that I thought was, one of the things that was going to make the difference for that organization to be successful, where you really do have this bottom-up approach of inviting the staff to be a part of the change process, and that it wasn't transactional. So I look at that and I think, okay, so if you're coming into an organization and there's big changes that need to happen, first you need to be able to identify the right people who are going to be a part of the change, and make sure that those people are willing to be agile in the process. The second is that you have to be able to recognize that once you come on board with that organization, as we did, we had to own our mistakes. And so I remember distinctly walking into meetings in Jacksonville with referral partners who were very well aware of Lakeview at the time and would tell us to quit because there was no way that they were ever going to refer to us. And I was like, I get your frustration, and I know that there's been a lot of bad stuff in the past, but we're going to tell you right now that we're going to be different, and we're going to own it, and we're going to make changes. And I would say that for any organization who does that, they have to put action behind what they're saying. It's not enough to just verbally say, we're going to be different, because people hear that all the time. We literally had to step up and do things differently, and we had to change our process internally. For example, we were holding on to clients for their full benefits, from detox all the way to IOP. Even if the client was referred by a high profile IOP provider in the community, we were using their IOP benefits instead of sending them back to them. And so we had to create tremendous education within the institution to teach people that our referral partners are an extension of treatment for us, and we have to build a collegial relationship with them so that they could go back and say, Lakeview is a partner. We're going to work collaboratively together. And we had some bumps in the road. It was a really hard shift at first. We had to really teach our team, from the clinical staff to the utilization review team, that we weren't going to do things the way that we always did it. And we made some mistakes, and we got hit over the head a couple times, but we had to go back and apologize, make amends, and make a change. In fact, there was a time where Roy got in his car and drove over to a referral partner's office and gave them a check for the money that we used to send a client to treatment, or to Lakeview, because we used that IOP benefit when we shouldn't have done that. And so intentionally showing and not just saying was a huge shift for us. And I think in our industry, we have to do more of that. I don't think we're doing enough of action-oriented responses to situations. We say a lot of things, but we don't necessarily mean it. And we have to be able to demonstrate that. One other thing I'll mention in regards to that is we're currently in a trust recession in our industry. I think globally we're in a trust recession where people are less inclined to trust in general. And the only way that they're going to trust is if you build authentic relationships with them. And we had to make a concerted effort to say, even though we were not a part of that guard that made all those mistakes in the past, we're owning it. We're telling you that we're sorry. This isn't the way it's supposed to be. We're going to make those changes, and we're going to give you the time to learn about us and who we are so that we can make those changes. So, when you ask, what are the variables that could be applied in other organizations as far as what we learned as a case study at Lakeview, the first thing I would say is you need to go in and own it. You need to own your mistakes. Like we talked about earlier, be okay with saying that you did something wrong and that you're going to work better and harder to make sure it doesn't happen again. You need to be able to build an authentic relationship, provide resources and materials to help support that person or that provider so that they feel like they're getting value. And then, make sure you identify the right people for your team that can help you move that ship. And that's not always easy to do. But I do think that there are some really powerful people out there that we can surround ourselves around to help us be better in our work on a day-to-day basis.
Mm. Another thing that I think would be valuable for everyone, just given all the years that we've sort of put against this, is really looking at uh, efficiency and what does that mean in between departments, especially. And the meetings that I always really enjoyed with you are the ones where we take people from different departments and we get together. And I think that's where you really build a brand. That everyone's living in silos. You're not working towards the same goal. You're not reinforcing the same messages in the world. And really, when I think of the work in behavioral health that is most successful, it's where we're really looking at all the external points of touch. And so that's marketing, certainly, but also business development, as you mentioned, admissions, alumni, all of that. And those are really the roles that were in these meetings. Fundraising, if it's a nonprofit. So speak to that, and what does that look like? How are you able to bring these departments, and maybe share some examples?
Yeah. So I would say this is one of the things that I get most excited about when I'm working with programs, because even today we're still seeing a lot of fragmentation in treatment, or in organizations. Whether you're an IOP or a sober living, or you're in a traditional residential program, it feels like there's still this issue of siloing that happens, where everyone feels like they're kind of doing their own thing, but nobody's talking to each other. And I can explain why that happens. Number one, the nature of behavioral health is incredibly dynamic. There's a lot of reactive versus proactive behavior, because we're talking about people in crisis. We're dealing with individuals that are suffering, and we're constantly moving. And so we don't stop to think about the fact that if we don't have the right systems in place, it can really fragment internally an ecosystem that really needs to be working synergistically. And so what I have found over the years working in facilities and now working as a consultant is that we still find ourselves in these silos where admissions thinks they know what they're doing, and marketing knows what they're doing, and outreach is doing their thing, and medical is doing their thing, nursing's doing their thing. But when it's time to really get together and start dialoguing on how we can work collaboratively, there's a lot of friction that evolves. And some of it is assumption. Some of it is that we make assumptions about the other person's department, the way they work, how hard they're working. So for example, I can't tell you the number of times I've heard admissions say, well, all outreach does is take people to dinners and coffee. Clinical will say they just bring them to campus and show people around, but they're really not working that hard. We're working harder. Nursing doesn't really want to take the calls after hours. They don't want to work that hard. There's literally perceptions and stories told about each individual department within the organization that really creates barriers. And those barriers ultimately, if you think about it, impacts the client at the end of the day, because the client will feel the division. They'll hear it, obviously. They'll experience it because staff is burned out. They're tired. They're frustrated with each other. And so from a kind of 30,000 foot level, if you're working in an organization and you don't have a good understanding or a good rapport with your admissions team or your case management team, or even your leadership team, then you aren't going to be effective in the work that you do, much less being effective in taking care of clients. And so a big part of what I call the micro tears in systems is this lack of synergy that needs to happen between the departments. Because when you're working in a facility, whether it's inpatient or outpatient, one lever you pull over here, whether it's in dietary or it's in housekeeping, will have a direct impact on care clinically. And so how do we build that? How do we nurture that so that we can get people all on the same page? Examples that I can give you: when I was at Harmony Foundation, the CEO at the time had, right before I got there, brought the outreach team together with the admissions team. There was a lot of friction between those two groups, and they were not working well together. There was a lot of disconnect between who was doing what. They didn't really know each other very well. They were kind of working in different buildings. And so before I arrived, he brought them in and got them under the same roof, which was a great start. When I came on board, the next step for me was to bring them together from a collaborative standpoint and start offering, weekly meetings with admissions, with marketing, with outreach. We would invite sometimes case management into that conversation where we would discuss the various aspects of what it was needing to happen for us to help clients get to the facility, from outreach to point of door, and then all the way through at the end of case management. And when we started having those conversations in our weekly meetings by bringing those teams together, we started learning about each other. We started learning about the frustrations that departments were having, and the fact that sometimes it was simple workflow issues. Sometimes it was just situations where, like, well, I didn't know you did that. I was doing that. Let's kind of pair it up and see if we can find the solution together. And then once people started working together, they realized that we were all a team and it wasn't about my silo, my issues. And then on top of that, I really empowered them to spend time in each other's departments. I wanted them to, learn about what each other's case management would travel with outreach in the field, or outreach would come in and sit in admissions and listen to calls and understand what admissions was going through. So those pieces really helped change the focus of my department, my suffering, the things that I'm going through, to, wow, this is a collective issue and we can figure it out together. I'll give you one other example. And this happens pervasively through every organization. So this isn't unique to just Harmony, but there are a lot of treatment centers that will have outreach team members bring people to campus for site visits. And there's very little to no preparation or communication with clinical about what's happening. Many times clinical is deeply frustrated by this process because they're being required to sit with referral partners when they come to property, when usually it's during their lunchtime or it's during documentation time, or they're being pulled in a hallway on their way to a meeting with a client, or they've had a really rough day with a client and they might need 5 minutes to take a break. And all of a sudden, an outreach professional is walking down the hall with a referral partner saying, hey, so-and-so, I want you to meet with this person. Tell them a little bit about what we do. And we felt, or what I know the clinical team felt at Harmony, was that they were being taken advantage of. And I think if you probably did a poll to most clinical staff, they would say, we don't really know who these people are. I'm being asked to do something that I don't really know enough about. What's the value to me as a clinician to be sitting with this person? And so after having a very honest conversation with the clinical director, and he said, we don't like outreach. Outreach just feels like they need to kind of bulldoze everything that we do clinically. We need to make changes. We both sat down and decided that we were going to build out site visits that were going to be twice a week, very intentional, communicate to the clinical staff who's coming, making sure that we had agendas set up, that we had a site visit like process put in place, that they knew that they needed to be somewhere for 20 minutes to meet with a clinician that wasn't going to interfere with the clinical day or documentation or their lunchtime. So the goal was for us to be responsive to the needs of what clinical needed. And we can do that with every department. If a department struggles with our department, we can sit down with them and say, what are your struggles and how can I help be the solution? And once we started having those conversations and dialogue, it changed the game for everything. Clinical was thrilled about having people on campus. They got a notification. The entire campus got notified before the client arrived, the referral arrived, so that they knew who they were. They knew their program. They knew what their resources were. It just made the process easier. But it all came down to that we have to treat our staff, the people that we work with, as constituents. They are people that are going to help us do our job better. And that means we need to sit down with them and learn from them and, change the narrative or change the story of our perceptions of what their department really is about.
Mm-hmm. Yeah, I think if you're not bringing people together and put these minds where they know each other, how can they fix or improve any part of the process between those departments?
Right.
And I think you're not taking advantage of knowledge that could help any one department in their work.
For sure.
There's obviously enormous benefit. The better BD knows what's going on campus, better they can communicate a story. I mean, that way it's not the same boilerplate. We're 57 beds and we do trauma-informed and gender specific. It just becomes these stale bullet points. But if you can add a recent story that really gives someone better understanding of the program and what makes it so driven and what it does.
Yeah.
Changes everything. It makes it more dimensional.
Mm-hmm.
Uh, and I think that that's always made a difference. Or even going in the other direction. BD is out there in the world. They can say, what we're seeing here is this. This is what people are saying about us.
Mm-hmm.
And that can influence marketing, and they can put
Yes.
together different materials.
Yeah.
Or, I mean, one of the ones that I really always find critical is admissions,
Mm-hmm.
where all this money is put at the top of the funnel, and then it's not, you're not capturing out of that as much as you need. And a
Mm-hmm.
tiny uh, increase in percentage there can mean the difference between being full or a wait list
Mm-hmm.
and being in desperation.
Right.
So what is
Yeah.
it that we can do to improve that?
Mm-hmm.
And there's learnings that we can get work from either listening to calls or getting feedback saying, what we're hearing these days is this. Okay, we might be able to get ahead of that higher up the funnel.
Mm-hmm.
Get some messaging in there to address it before we find out we've lost all these people and are just hearing it from the people who still made a phone call regardless.
Yeah.
There's so much that can come out of it, that I think is critical, and especially the what I try to have a format in meetings is to build together a longer term strategy, but make sure you're reflecting on it at least quarterly, and
Mm-hmm.
make sure that there's ideation around that. So
Mm-hmm.
not just waiting to the end of the year and saying, what do we want to do next year that we didn't do this year? What do we like that we did? And really have some organization around those meetings and say, okay, did we address this? Can we course correct now before we've got an entire year?
Mm-hmm.
Before we looked at it and go, oh, guess we didn't do any of this stuff. Or we applied all this effort to an initiative that on its own looked like it was performing, but really didn't contribute to any meaningful business objective.
Mm-hmm.
Um,
Yeah, we can call those. I mean, a couple things is I'm going to kind of point out what you just said is we all have the opportunity to be teachers and learners in our organization where, like you mentioned, we hold a lot of intellectual capital around our department, and it's our responsibility to educate others within our organization about what we do and even what we struggle with and even the things that we're doing really well. And I think sometimes we don't take the time to do that. So being a teacher and learner in that environment is an opportunity for us to be more synergistic in our messaging, like you mentioned, in our clinical care, and really at the end of the day, optimizing, a client experience. Because if a client's hearing in the field from an outreach professional that we do XYZ clinically, and they get a phone call or they call admissions, and admissions is saying what they heard in the field, and it's succinct, and then they get into treatment and they're experiencing what they heard from the field admissions and now they're in program, it's just going to help level up your credibility in the field. It's going to help you with referrals. It's going to help you with customer engagement. Exactly what you're saying. It's like we have to be able to apply our knowledge base to help support others in the organization to understand that. And then to the second point of, how are we strategizing in a way that allows us to really do, meaningful pivots if we need to. And 90-day sprint plans are great. Do a like I know that when I worked at Lakeview, we would identify 4 key, they weren't BHAG or goals, but they were goals that we would say collectively as a team, what are the 4 key things we want to work on in the next 90 days? And then we collectively make that decision. We do it by consensus. And then we say, okay, these are the things that we're going to focus on. And then we're going to work at the end of 90 days to see, did it work? Did it not work? Do we need to pivot? Do we need to roll things over? And again, that's why those meetings have to be, in my opinion, not just like I call them kind of like regurgitating meetings where you just sit there and listen to somebody talk, but it's really an intentional discussion around how are we going to make change, and using those sprint plans is a great place to start.
mm, yeah, I agree. 'Cause there's enough barriers to treatment
True.
already.
Mm-hmm.
Have to make this as seamless as possible
Yeah.
as they go through. Because it's if you're not looking at the right numbers, and I think many organizations see numbers and say, okay, this is a higher number, a lower number, it means better, but it doesn't always. And so,
Mm-hmm.
I think length of stay is a good one to look at for
Mm-hmm.
that, because you might have this uh, BD person or a referral source that you think is delivering gangbusters for you. But then you look at the length of stay and realize these people aren't staying.
Mm-hmm.
What are we telling these people, or what is the misperception of this referral source where they're saying, okay, this is a certain program person. I know it, but it isn't. And they get there and they end up leaving. So
Yeah,
yeah,
but I think one of the challenges though, Kevin, is that it's interesting. Everything you're saying is exactly right, and that we need to start thinking differently. But we have so many people in the industry that are, as I mentioned before, moving so fast that they don't take the time to step back and actually ask those questions. And so that's part of the problem, I think, is that you're asking very intentional questions of like somebody comes in, we're getting the phones to ring, they're coming into treatment, but the length of stay is, half of what it should be. Is it the outreach responsibility? Is it the admissions responsibility? Is it the clinician's responsibility? I mean, are we doing enough, motivational interviewing and training for clinicians to help keep clients in treatment? I worked with a program recently who their AMA rates were very high, and it typically happens during detox. And so what questions are you asking to address that? Are you immediately going to outreach and saying you guys are bringing the wrong people in? Or are we looking internally and saying, in detox, are we offering the right programming to help keep them in treatment so that they're not bored and just sitting around for 7 to 10 days? Or are we, instituting a clinician in detox that can sit there and work with the clients and actually start treatment while they're in detox versus them feeling like they have to wait until they're, clear-headed enough to go into group. And so those questions that you're asking are very intentional questions, but we sadly live right now in a industry, and it's specifically in a field where everything is moving so fast and so dynamic. As I mentioned earlier, we're reactive versus being proactive. And I don't know what the fix is there, other than to suggest people need to just take a breath and slow down and really kind of be more intentional about the questions that they're asking.
I think there's too much of a desire to feel busy as opposed to really doing. They want a high volume of work.
Yeah.
They don't really want to think.
Mm.
And so, even with the detox, I think there was, a program that I felt really inspired by because they didn't look at their detox as just a detox. I think there's some places that look at detox or IOP specifically as well. And they go, oh, this is just what it is. And it's very cookie cutter. But you can spend the time to go, well, what can we accomplish there to maybe help the conversion rate to the next level of care? What can we do to keep them motivated? Help better prepare them? That's going to benefit the client. That's going to benefit the organization. And it's really just spending the time to say, well, let's just put fresh eyes on this. Let's get everyone to look at it and go, where are the potential faults? Where are the potential opportunities? Let's look at the competitive set. Maybe we haven't looked at that in a while and say, what are people doing? Oh, that's a really interesting idea. Maybe this is our own flavor of that. And I think that's where you look at brand, because I think most people think of brands as palettes and fonts and logo and really those who, are educated in brand and marketing know that there's things like, 4 Ps. And this product. Okay. Oh yes, brand influences product. So I mean, I think when we look at that, how does it influence everything, everything that we do? And I know you commonly introduce that by saying, what is the why behind what we're doing here? I think as leaders or even just peers in the groups, I think we have to maybe, without always looking at making it seem as if we're slowing things down intentionally, or why don't we just get it done? But doing it, I think that's where waste methods have to be done in order to make sure that is part of the process.
Yeah. And I know a lot of people know about the traction model. It's a model that's usually developed by early entrepreneurs and who are building companies. And they have an entire formula for that, and really looking at the brand, understanding your avatar, knowing what their characteristics are. I mean, I know that Psynchronous does a really great job of like walking clients through the process of identifying what is your brand. And it is much, much bigger than just colors and fonts and, images. And do you really understand the voice and tone of the type of client that you want? And I think when you're talking about brand, a lot of our programs think that they might have 1/10 of a brand book together, but they don't really have a full understanding of it. And so utilizing somebody who can help work with them on asking those questions could be really beneficial for them and getting clear around, because I think sometimes what we find is a lot of people shotgun their efforts. They're like, it's just, just get out there and start talking to people. I hear that a lot from outreach professionals. I didn't get any training. I was just told to go out and start setting up coffee meetings. But with who? Well, just anybody. But do you know what that person even has the ability to send you clients? No. Do you know how to do that? No. Do you know what your client is? Do you know who your ideal client is? What they're, what kind of insurance do they have? What kind of, clinical diagnosis do they need to have? And a lot of times they don't, because our leadership and our marketing departments don't know, because they haven't taken the time to do what you're talking about. And so that really does need to be a fundamental part of the process of development. And then once that's designed, like you said, you bring everybody together to have that conversation, then everybody's on the same page. And then you have somebody who's the overseer to make sure that the integrity of that is, consistent, and that it's being carried through from the outset all the way through discharge. And so there is a lot that I think is missed when we don't have those conversations.
Mm. One of the areas that we're both deeply passionate and is rooted in collaboration, our alumni departments.
Mhm.
And I think that continues to be a little bit of sort of the sleeper booster that
Mhm.
everyone really could take advantage of. How did you initially become passionate about alumni?
The first alumni, okay, so I worked for a program in Virginia, and I just out of the gate, I'm not a person in long-term recovery. Clearly, I've had people near and dear to me that have died from the disease. And so I'm, I do this work for them. I do this work for those that I work side by side with who are in recovery, who, work every day to stay sober. And so I wasn't a person in recovery. And so I was very insecure when I came into this field. I wasn't sure what I could contribute in any kind of meaningful way. And that sort of escalated when I was working for this treatment facility. And that one of the clients, actually it was an alumni, was standing in the conference room, and he said, "So you're our new alumni coordinator?" And I said, "I am." And he said, "Are you in recovery?" And I immediately was uncomfortable, and I was like, "Oh, what do I tell him? I'm not. How can I be of service to this person?" And I said, "No, I'm not in recovery." And he kind of looked at me and he was like, "That's okay. I'm sure there's something you can teach me." And that was sort of my aha moment of like, okay, I don't have to be a person in recovery. I just have to have empathy and compassion, which I do, tremendous, and a great deal of respect for people who are working through mental health and, substance use disorder. And so I was introduced to the alumni world in 2007. And I was asked to facilitate like a homecoming, not really understanding what the nuanced nature of what that meant and how to build it. And I did it. And I was so impressed by all of these folks that came back to campus who wanted to share their story, even if they were 5 minutes sober or 25 years sober. There was something really beautiful to watch how these folks were coming back with a second lease on life, and they wanted to share their strength, hope, and experience with others, including the clients that were in treatment. And to me, it was like I needed to see outcomes of the work that I was doing. I came from a prevention world before I stepped into treatment. And in prevention, it's always really hard to see the outcome of your efforts. But in treatment, you can see the immediate response or the results when somebody's getting better while they're in treatment. But even more so when they come back and they have their family back, their kids back, they're happy, they feel hopeful. And so that was very inspiring to me to want to work with an alumni community and be a part of a recovery community where you could see the fruits of their labor and all of their hard work paying off. And so from that, I continued to work with other programs and got introduced to TPAS as a volunteer when it was in its early infancy stage. And that really kind of took things to a whole new level, because then I got to work with other people like me that were building alumni programs. Many of us who, really felt like we were siloed and kind of on our own now had a community of people that we could work with. And I was really excited to hear about what they were doing and sharing that with others.
Yeah, I think there's people underestimate, I think, what an alumni program can
Mm.
bring. And, there it's you look at how do we maintain people in long-term recovery? How do we use our alumni as an example of the outcome of treatment and focusing on those stories and that
Mhm.
positivity? I mean, I think they can be your greatest referral source and at the lowest cost per acquisition that you can
Mhm.
imagine. Um, but it's funny when we think of legacies and things like that, because sometimes there's one moment, and Jim mentioned it in the podcast that I did with them, where sometimes it's just certain moments that someone will take away, from knowing somebody. There's something that I sort of applied to the alumni world that wasn't initially sort of what this person was trying to convey. It was at, I believe it was the Cape Cod Symposium, and Ray Tomasi
Mm.
was leading Gosnell back then, so it's going back many
A
years.
little bit.
But one of the things he mentioned was, okay, what they really wanted to focus on was looking at the number of days between relapse and readmission, and they wanted to reduce that as much as they possibly could. And I think that's sort of a metric that isn't focused in on enough. And what we didn't know way back then is almost the world that we're living in now. When we look at the potency of substances and looking at complexities of polysubstance use, how critical reducing those number of days are, and what can you do with your alumni program to influence that? If you've had continued trust that you have, where you know that you will call that back that program, great. If you're
Mm.
reaching out to, with your alumni program to others in who are in recovery, maybe didn't graduate from your program. Okay. Bring them in. Let them know that you're here. Let them know your way of doing things and what you think is important, what influences the success of your program. But I think that's just another example where are we looking at the right numbers, and what are ways that we can look at the way our alumni program is performing other than barbecues and
Mhm.
fun and recovery events, which I believe in.
Mhm.
But I think there's other types of events that can be extraordinarily beneficial as well.
Mhm. I tell everybody that I work with who are, working in alumni, or even those that are not, once you see one alumni program, you see one alumni program, because they're not all the same and they're not intended to be the same. There are some variables that you want to include in building out a community of recovery support, which is really what it is. I mean, remember, if you're building an alumni program, it's not just that one person that's coming to your program. They might be an alumni of 3 other facilities. And so you're not trying to compete against others. You're trying to offer a recovery support community that's going to assist in that remission rate that you're talking about. How do we build in longer lengths of remission so that when we know that this can be a relapsable disease, how do we help support them in those early stages? And, as I've talked to many people, the field of alumni services has changed dramatically in the last 16, 17 years. I mean, our first sort of, what do you call them? Early adopters of alumni, the Hazelden, Betty Ford. Betty Ford was the one that charged, Leonard Bade to go out and start meeting with people. There was no rhyme or reason to it. It was just, we know that we stay sober in community. So how do we build that? And so in her mind, treatment facilities needed to get out of being behind their 4 walls and start getting into community so that folks can actually stay sober longer and stay well longer. And so she had a vision, and her vision was to bring community closer to the facility, and the treatment had a responsibility to help support clients well after they discharged. And over the years, you've seen programs like Karen and others, Cumberland Heights, build these really robust communities where you can actually look at the data and know that their folks are staying sober longer because they built these micro communities of recovery where folks feel safe. They feel like they can, stay engaged. Sometimes it's in 12-step meetings. Sometimes it's in sober, recovery oriented systems of care groups. But in the sense of alumni programs as it relates to treatment, we do have an obligation to create those recovery communities, because those communities can make the difference in somebody staying well and staying sober longer, or if they slip, because it can be an incubator for practicing their recovery skills, they can slip in a place where they know that they can get the help that they need and that they're not on their own. And I think that's the thing that's so amazing about working with these alumni communities is that they were there to catch you. And they're there to help support you in your wins and your successes.
Mm. And really, for anyone who's not involved in TPAS, um, tpass.org, like it's a must. I mean, I think it's the biggest no-brainer you could possibly do.
Mm-hmm.
For a very small amount of money, you get so much continued support, education around development,
Mm-hmm.
ways to think and approach the alumni program world. It's not just another membership organization that one belongs to just to belong. Um,
Yep.
I think
And the
not.
peer community, just the peer community alone. I mean, that to me is probably the highest value of being a part of an organization like TPAS is that you're connected with over 250 peers that are doing what you're doing all across the country and in Canada that are dynamic, that are on fire about recovery and mental health wellness. And they want to share and they want to build relationships together. I mean, that's the thing that seems to set us apart from so many other organizations is that we have a very active, dynamic community of peer support.
Yeah, it's different. I mean, even I remember you describing the collaboratives to me like it was yesterday,
Mm-hmm.
and saying, okay, it's not a conference, and it's like, okay, it's not a conference. It is a different experience altogether. It
Mm-hmm.
really is, in the way that it's developed and expanded. Um, it continues to develop new ways to support alumni programs. But what I also really love seeing is the more brains that we're putting against all of this, the better it becomes. So now it's grown to having more international perspectives being introduced,
Mm-hmm.
and that's amazing. And I also love how when I'll go to a collaborative, I'll see people who are not just alumni professionals that are attending, but increasingly more CEOs, business development people, or
Mm-hmm.
marketing people.
Yep.
I think that's really critical, and I think we're only scratching the surface of what this will ultimately become.
Yeah. And, Steve Millett, who's on our board now, 30 plus year veteran in the behavioral health field, went to his first collaborative this year and said, this is like nothing I've ever seen in the 30 years that I've worked in this business. And, was deeply moved by the meaningful connections that were being made real time through the Peter Block process and the conversations to even the process of open space and how we design our agenda so that everyone feels like they're collectively involved in the process. He just said it was a game changer for him. And so to have somebody who's seasoned like he is, who's been to probably thousands of conferences in his 30 years of being in the field, it was really a compelling testimonial from him to hear that. So I agree with you. If you're a leader in the industry and you need to get something new and fresh, we invite you to our collaboratives because they're a game changer.
Quickly, and this is a broad question,
Mhm.
but what do you see as the future in behavioral health? Whether it's an upcoming challenge or an upcoming
Yeah, it's an interesting question to ask in this time in our political climate, right? So, um, consolidation is continuing to happen and it's not going to stop. I think we're going to continue to see consolidation of programming. But back in the day when I came into the field, there was still a lot of homegrown programs that were coming up. Those are not around as much, or if they are, they're starting out that way and then they're ending up being bought out by larger entities. Um, it concerns me a little bit about that because that's where you start to get this competitive sort of scarcity mentality. And we haven't touched on that. So I'd like to think that in the future, we're going to move away from scarcity, this fear of not having enough, this fear of greed, this fear of, my program is never going to have, enough clients in it, which I think we can all agree. Sadly, there's too much business to go around. We're just too busy fighting for the same 10%. And so I like to see us moving into a space of sufficiency where we can actually look and know. And actually, this is the case. If you haven't read the book, The Soul of Money by Liz Twist, she talks about this idea of at the first time in our civilization, we have more than enough resources to combat issues like hunger, homelessness, There are more enough resources globally to handle that. The same can be said for treatment services. There are enough resources to meet the needs. And we have to just remember that we have to stop competing against each other around that. So I like us to see in the future that we can move into more of a collaborative space like we do with TPAS, where we want to work together to solve the problem. But my fear is that because we're in a space of consolidation right now, these larger industries and businesses don't really tackle it that way. They're really looking at it from a standpoint of, I've now acquired my 10th, 11th, 12th, 13th treatment center, and I need to have it at 60% capacity. And in order to do that, we need to do X, Y, and Z practices, and some are ethical and some are not. And so, and just the nature of what's happening in the world around Medicaid and, giving access to treatment for those that need it the most, that are really suffering. And the fact that that's being cut is very concerning. So, it's a very different world than what it was when I came into the field almost 20 years ago. And I think we're going to continue to see more acquisitions happening, which is going to make it much harder for the smaller mom and pop programs to do the work that they're doing. I don't like to sound cynical, but it feels like it's just going to be more of a challenge, which I guess I would say I would like to challenge people who are listening to approach their work that they're doing in behavioral health from a space of sufficiency, and to look at that we all have the ability to be a resource and to help be a support for those that need it, and that we don't have to come at it from a place of fear.
Yeah.
Be my challenge.
The easiest thing is to throw money at it. I think
Mhm.
we need to look at this particular challenge as a learning opportunity to maybe do
Yeah.
things a little bit differently, get out of our comfort zone, and
Mhm.
try to be smarter and more efficient.
Yep.
And I think that's where there's judo strategy techniques that can be done, where you can say we can still thrive as long as we're just not acting in desperation. Because when we act in desperation, we're quickly going to be in a place where we're not thinking well, and you might pull yourself in some unethical situations, or just
Right?
not being in the right
Exactly.
headspace, period, to
Mhm.
show up in the way that you really need to.
Yeah, I completely agree. So it's definitely possible.
Okay, so for everyone listening, we'll put links in the bio to
Mhm.
how to get in touch with Gina or TPAS or anything else that we've discussed, including her YouTube
Yes.
channel where she traveled the world, which I recommend.
Thank you.
Okay, Gina.
Hmm.
The behavioral health care field has always been evolving, but today's changes are unprecedented. Government policies and funding reductions, workforce scarcity, polysubstance complexity, and population health trends all hold implications for patient symptom acuity, the evidence base, access to the continuum of care, and provider viability itself. Barriers old and new are making the process of accessing quality treatment as daunting as ever. Soon, whether due to reimbursement rates or parity changes, value-based care requirements, or even wholesale shifts in the public treatment efficacy narrative, cost-effectively sustaining client census will become more important and potentially more challenging than ever before. As the sands of search are shifting, and authority is the coin of the realm, being seen and earning clients takes even more. The best SEO and advertising, social media, and outreach can't help unless prospective patients, families, and referrents immediately and consistently perceive your excellence. Now, more than ever, your program's representation and reputation matter most. For 20 years, Psynchronous has helped behavioral healthcare providers refine and project the nuanced differences and commitment to quality that make them attractive to their client cohort through superlative brands and messages, demonstrable subject matter expertise, multi-channel communications, and materials with meaning. When it comes to behavioral healthcare, it is our experience that people much prefer a flight to safety over a leap of faith.
I've worked in sober housing, I've worked in intervention and family consulting. I
And when it comes to accurately, ethically, and compellingly positioning behavioral healthcare organizations and nonprofit missions to prospective clients, families, and professionals, having partners who understand that the business of behavioral health is about much more than just business makes all the difference.